And I'd like to introduce our speaker today. Thank you all for joining. This is Vijay Batuman, and it's my pleasure to introduce our speaker today, Dr. Madelaine Feldman. She's a rheumatologist in private practice with the Rheumatology Group in New Orleans, and she is the president of the Coalition of State Rheumatology Organizations. She's the chair of the Alliance for Safe Biologic Medicines and past member of the American College of Rheumatology Insurance Subcommittee. Dr. Feldman is a clinical assistant professor of medicine at Tulane University School of Medicine. She lectures extensively to patients, physicians, regulators, and legislators, both locally and nationally. She travels, or at least was traveling frequently to Washington, D.C. She has appeared before the Health Subcommittee of Energy and Commerce in 2019. She has spoken and written on the drug supply channel, particularly the effect that formulary construction and utilization management tools have on pricing and access to drugs, availability and affordability. Dr. Feldman is the recipient of Distinguished Service Award from Tulane Medical School. She was named one of the top women in New Orleans by City Business in 2017 and is the former radio talk show host of Driving with Dr. Maddie. It is my pleasure to turn it over to Dr. Feldman. Thank you, Dr. Feldman.
Thank you so much, Dr. Otterman. So today, I'm not sure how much interest there is in this particular aspect of drug pricing, but I'm hoping by the end of my presentation that I can get a couple people standing up with pitchforks after hearing what I have to say. Of all the hats that I was introduced wearing, my favorite is being a private practice rheumatologist here in New Orleans, and I've been so for the last 30 years. So a few disclosures, advisory board for the manufacturers you see there. And I always want to preface when I start talking about blame for drug pricing, it's not that, and I'm not necessarily blaming pharma during this particular presentation. And I want people to understand that I'm not actually, shifting the blame to someone else. We're sharing the blame. There's more than enough problems with manufacturers and drug pricing. I mean, here are just a few of the egregious pricing issues. Let's take colchicine. Colchicine is something that I've been prescribing, as I said, for over 30 years, started off at 4 cents a pill. Someone did a couple studies, went back to the FDA, got it to be their brand name, and then it was $10 a pill. We're all familiar with the Daraprim, Martin Shkreli controversy, taking Daraprim, which was $13.50 a pill, and changing it to $750 a pill. And the one that I think bothers me the most is ACTH gel. When I was first out in practice, I would carry around a vial of ACTH gel in my pocket for patients with acute gout, and that vial costs $40. How much do you think that vial costs today? Nearly $40,000. So there are some definite pricing problems with manufacturers. And then, of course, another one of my favorites is the generic price fixing cartel. And it's some of you'd recognize these generic manufacturers, the price fixing that they've done to make generic drugs go up in price. But we're going to leave that aside for now, and we're going to concentrate on the general aspect and the problems of drug pricing. And I look at it as waiting for Godot. We've been trying to do drug pricing reform, and some of the adjectives that describe theater of the absurd, I think actually describe fairly well what our approach to drug pricing here in the US. I was a theater major undergraduate at Tulane, and so this is still a little bit close to my heart. Disjointed, repetitious, meaningless, confusing, futility, and human struggle. I think all of these things describe pretty well what we're trying to do in terms of drug pricing reform. So let's look at the concept of access to medication. And I look at access as having two different qualities. You have to have availability to the medication, and you have to have affordability. If either one of those are not there, you're not going to have access to the medication. So in terms of availability, as we all know, you're not going to be able to get the drug if it's not on the formulary. So for those of you who may not know what the formulary is the list of medications that the insurance will pay for. And then, of course, affordability, whether it's the actual list price of the medicine or whether it's the patient's cost share through their insurance company, it has to be in line with something that the patients can afford, or they lose access to the medication. I mean, the bottom line is if an expensive drug, and as a rheumatologist, I prescribe a lot of very expensive drugs. If it's not on the formulary, no matter how great the drug is, no one's going to take it. You know, unless of course you get it through a foundation, you get it through samples in the office, you know, or if it's given to you free in some way, shape, or form. So it has to be on the formulary, particularly in the commercial and even in the Medicare, in the Part D. There is tiering. So I hope by the end of this presentation, you'll sort of get an idea that formulary construction in America is extremely important in terms of patient access to the right treatment, and that it's perfectly legal, but again, that it's perfectly wrong. And I hope that you'll agree with me in that by the end of this. So who constructs the formulary? Well, it's an entity called Pharmacy Benefit Managers, otherwise known as PBMs. And then what maintains the formulary that the PBMs construct? Utilization management tools. This discussion is not about utilization management tools. I'll mention a couple of them because they are important in terms of maintaining the formulary that the PBM wants to have. But let's talk a little bit more about what a PBM is. So they came into being probably back in the 70s, probably with Medicaid to adjudicate pharmacy claims. But over the years, they've become more and more important, particularly once drugs started getting more expensive. As we remember, insurance companies really wanted to pay for hospitalizations, surgeries, you know, maybe even doctor visits. But when it came to drugs, as soon as it started to get more and more expensive, they needed an entity to essentially have cost containment, and voila, then came the PBMs. And back in the 90s, you might remember pharmaceutical manufacturers wanted to own PBMs. There was Merck Medco. The Federal Trade Commission came in and said, look, you can't make the drugs and decide which drugs patients can take. So they put the kibosh on manufacturers owning PBMs. So essentially now they adjudicate the pharmacy claims. They decide how much the patient's going to pay and handle all of that. The most important thing, and the thing that I'm going to talk about a lot today, is how they construct the formulary, and it's supposed to control costs. They also determine the patient cost share, and they also set up the pharmacy network. So they're pretty strong in terms of determining what kind of medications our patients can get. So who are these pharmacy benefit managers? And you may recognize some of the names. I don't know if my pen is coming across on the screen, but the three across there, until about a year to 2 years ago, Express Scripts and CVS Caremark had no association with an insurance plan. United Healthcare started OptumRx, and last year, CVS Caremark, which is the PBM for CVS Health, managed to cobble together $68 billion to buy Aetna. And then the year before, Cigna purchased Express Scripts. Part of the reason everybody wants to own a PBM is because they make money hand over fist. In 2017, Express Scripts was number 22 on the Fortune 500. Their revenues exceeded Johnson & Johnson's, who was number 33. And Johnson & Johnson makes everything. So how does a little middleman like Express Scripts get to number 22 on the Fortune 500? Let's see. Oh yes, let's talk briefly about utilization management tools, because these are what are used to keep the formulary, according to the PBMs, to create the most savings. But I would posit that it's to keep them the most profitable. So step therapy and non-medical switching, prior authorization, these are all tools utilized by the pharmacy benefit manager to keep the formulary exactly how they want it. As you know, step therapy, otherwise known as fail first, there's a list of drugs that patients must take first before they can get to the next step, and that's the step therapy. Non-medical switching is probably one of the worst, I think, of utilization management tools in terms of the way it affects patients. A patient will be forced to change their drug because it's just dropped by the PBM, and it could be mid-year. So you sign up for a particular health benefit because it's covering the medicine you take. 6 months later, they can change the formulary, and it's perfectly legal. I testified last year at an Illinois State Senate committee hearing, because they were trying to pass a non-medical switching bill. And I tell you, it's tough going, because when that happens, sometimes the middlemen lose a little bit of money, and they don't like to do that. So they come out full force with their lobbyists against any of these utilization management tool pieces of legislation. And we're doing it more in the states than the federal government because it's a little bit more nimble. There is a white paper that I co-authored called The Impact of Step Therapy Policies on Patients, and that was published last year, and you can see the reference down below. And I can tell you there is harm to patients with step therapy, both physical, emotional, and monetarily. So PBMs claim to save billions for our healthcare system. PCMA is the trade group for all the PBMs, and they've actually been advertising on television, claiming and touting how many billions of dollars the PBMs save our healthcare system. And they claim to do this through designing formularies based on negotiated discounts. They're not really discounts on the prices at all. I'm going to show you, these are really secret kickback packages. And I can call them kickbacks without, fear of any kind of litigation, because in order to accept these, they need to have safe harbor from the anti-kickback statute, because they are kickbacks. Anyway, these kickbacks are based on the list price and market share of the drug. The other things, they claim that these utilization management tools like step therapy and non-medical switching, employers are asking for them, and they're just giving employers what they're asking for. But in reality, they keep patients on the most profitable drug for the middleman. And most employers have no idea what they're signing. I started giving this talk about PBMs to like Rotary clubs, because they have business owners, and they would come up to me afterwards and say, I sign the exact same health plan every year. I have atrial fibrillation, and my drug was just dropped mid-year. I can't get it anymore. I've had to be cardioverted. Now I'm on 2 drugs, and this is the employer. This is the owner of the business. I doubt if they would have signed a health plan that would drop the only drug that was keeping them out of AFib. So this idea that employers want them, I think is kind of pie in the sky. They also claim to have more affordable pharmacy channels, and that is an entire lecture on itself. Community pharmacists, I will leave that fight to the community pharmacists. And then the big thing that they always talk about is they encourage the use of generics and affordable brands. I can tell you, higher price and brands are often preferred. And how I know that, and how it finally came out last year when I testified before the Health Subcommittee on Energy and Commerce, sitting right to my right was the representative from PCMA, a delightful woman by the name of Kristen Bass. And after my talk, Chairwoman Anna Eshoo from California asked Kristen, Dr. Feldman says that you put higher price drugs on the formulary over lower price drugs. Is that true? And Kristen said, no, we put lower cost drugs, and we put the lowest cost drugs. And I said, they may be lower cost, but they're higher priced. And Chairman Eshoo said, I'm asking you, are they higher priced? And Kristen just kept talking about cost. Finally, she pointed her finger at her and said, I don't care if they're lower cost. Do you put higher price drugs? And Kristen had to admit, yes, they do put higher price. And if we're a country in the middle of a drug pricing crisis, why would we have formularies choosing higher price drugs over lower price drugs? I'll show you why. So if you look at it through the formularies that they create, they determine what medications our patients can take. By the step therapy and non-medical switching, they determine when our patients can get them. By determining the pharmacy network, they determine where our patients can get their medication, and they also determine the patient cost share. So PBMs ultimately determine what, when, where, and how much it'll cost our patients for their drugs. So let's break down the drug money services flow. And I kind of like this slide because it sort of reminds me of a very sort of pared down immunology slide with different feedback mechanisms and enzymes and things like that. But as you can see, right in the middle is the PBM and the manufacturer. And that's the relationship, that's the contract that I'm going to be, even though it's completely proprietary and we have no idea what's in it, that's going to be the area that we're going to concentrate on today. Because placement on the formulary for the manufacturer is done by the PBM. And what determines who gets the placement? The rebate and fees that the manufacturer pays to the PBM. Now, we don't know what those rebate and fees are because, again, this is a contract between two free enterprise companies in the United States, and we're not in the business of opening up private contracts. However, once again, with a drug pricing crisis and with the potential that this is increasing drug prices, I would like to think that we would look a little bit more into that relationship. One thing that has been harmful by this, the integration that I talked about earlier with Cigna buying Express Scripts and CVS Caremark buying Aetna, is that it used to be the health plans would be looking over the shoulder of the PBM. And maybe about 3 or 4 years ago, Anthem sued Express Scripts because they learned about all these rebates that Express Scripts was getting, and they weren't getting passed back to the health plan. And Express Scripts countersued the health plan, and eventually Anthem fired them. Well, now we no longer really have health plans looking over the shoulders of the PBM because they either are owned by or own the PBM. So it's, instead of having a small black box, now we have this big black box. We don't know where how much money is going into it, and we certainly don't know how much money is coming out. So I hope you agree with me that placement on the formulary is very important, particularly for expensive drugs. For less expensive drugs, we have, you know, discount cards, GoodRx. A lot of times you can afford it without it being covered on insurance, but the specialty drugs, you know, the biologic drugs, even the non-biologic disease modifiers in rheumatology are all very expensive, with list prices, you know, maybe starting at $5,000 a month and going up from there. But what may be even more important is the preferred formulary. First off, you want to get on the formulary, because if you ain't on the formulary, nobody's ever going to take your drug if it's expensive. But if you get preferred, then you get to be utilized first. So why do manufacturers fight for this preferred placement? Well, because patients have to fail your drug first because of step therapy. With non-medical switching, you might be able to have an entire market share just put right on your drug when the pharmacy benefit manager changes formularies and make yours the only one available to treat a certain condition. And it excludes competitors to your drug. None of the manufacturers state that they sign exclusionary contracts. One way they get around is they sign what are known as performance contracts, meaning the PBM, the manufacturer who maybe has the largest market share and maybe wants to get one of their other drugs on formulary says, unless my other drug has 80% penetrance by the end of the year, I'm going to take away the rebates from the PBM. That gets into something called a rebate wall. And I'm not really here to talk about that, but it's just, there's just so much anti-competitive behavior going on in this particular way we handle our drug supply chain. It's probably 2 or 3 lectures. But anyway, these are some of the reasons why it's really important for a manufacturer to get preferred placement. So what determines preferred placement? Well, we'd like to think efficacy. You know, because a drug has been approved by the FDA, I'm sure it's efficacious and I'm sure it's safe, but are those the qualities that get you preferred placement? Perhaps it's the lowest list price, because all we hear about is reducing costs for drugs and extracting these discounts from the manufacturers. So it must be the lowest list price that gets you preferred placement. Guess again. It's the rebate story. But what has become more and more evident over the last couple of years, as health plans have found out about rebates, as the general public and Congress has found about rebates, there's a sneaky way of reclassifying rebates as fees so that they don't have to get passed back to either the employer or a different health plan. So we can't forget about the fees. So this is how it works. It's essentially a bidding war among the drug makers to get the preferred place on the formulary. And it's a pretty, this is my attempt at PowerPoint art. So imagine all these little green discs as the bidding manufacturers all sending in who can send as much money, essentially, into the pharmacy benefit manager to get placed, particularly on the preferred formulary. So as we all remember, I mean, rebates started a long time ago, and in this case, it's a retroactive sum of money paid by the manufacturer to the PBM for every script that's filled. And I'd like to think it's in exchange for preferred placement. So for example, if there's a drug that costs $100 and the rebate is $50, every time Express Scripts fills that prescription, the company that makes that drug sends back $50 to the PBM. So they ultimately paid $50 for the drug, but the list price is $100. So this is how it works. We have an equation. So your total formulary rebate is basically the combination of these three variables. So it's the list price. Let's use something easy like $1,000 a month. And the percent rebate is 50% rebate. So they will send back $500 to the PBM for every script that's filled. So the total rebate amount will be the list price times the percent rebate promised times the number of scripts filled. So as we learned back in, I guess, early algebra, if you increase any one of these three variables, your total is going to go up. So it's very difficult for a manufacturer to increase their market share. I mean, you basically have to be preferred on the list to increase your scripts filled. So that variable is difficult to raise on your own. So you can promise a higher rebate. So for example, instead of giving a 40% rebate, you can give a 50% rebate to increase your chances of having the highest bid. But the easiest thing to raise, of course, is your list price. So an increase, as I said, in any one of these gives you a better chance of preferred placement. So let's look at an example of how this works. So we have drug A, B, and C, and they all treat the same condition. And as you can see, drug A is $2,000 a month, drug B $4,000, and drug C is $5,000. So drug A figures, well, I don't cost as much. My price isn't as high, so let me offer a bigger rebate. So they offer a 60% rebate. So their total formulary rebate comes to $1,200. And then you can follow this along. You get the 40% off on either the $4,000 or $5,000. And we see, in spite of the fact that it's a lower percent rebate, it's a higher list price. So their formulary rebate that they send back is $2,000. So guess which drug do you think will be preferred by the PBM? Correct. And I can give you an example today. And without naming names, there are 3 drugs in a particularly relatively new class, maybe over the last 5 or 6 years, for rheumatoid arthritis. One that is $28,000 a year, one that's $55,000 a year, and one that's $65,000 a year. This is the one that is getting all the play on all of the formularies, not this one. So this price concession bid is, as I said, is a combination of the formulary rebate plus fees. Now I have the fees being larger than the formulary rebate, and we've always thought of the rebate being the biggest part of the price concession going back to the PBMs. But I'm going to show you, I don't know, let me see if it's the next slide. Yep, it's the next slide. Okay, so this is a very busy slide. Let me just sort of set the stage for what's going on here. Back in 2016, Kaleo, which is a manufacturer out of Virginia, they made Evzio, which is essentially a Narcan pen used in people who overdose, obviously, from opioids, is probably one of what it is used for the most. And it came onto the market a little over $900. And they got into a contract with Express Scripts. And back in January of 2016, for the month of January 2016, this is the amount they paid to Express Scripts in formulary rebates. This was their admin fee. This is a price protection rebate. So if the drug gets raised up over a certain threshold, more money goes to the PBM. So the total was $32,000. In April of the same year, the cost of the Narcan pen went from around $900 to a little over $4,500. And yes, the formulary rebate jumped from $1,600 to $7,100. Look what happened to the admin fee. And look what happened to the price protection rebate, nearly $5 million. So what happened by the end of that year, Kaleo really just didn't have the money to pay all of these rebates and fees. So Express Scripts sued them. And then Kaleo countersued Express Scripts because they said, you promised us a market share that we never got. And that is because of this countersuit, that is the only way we were able to find out exactly how much the formulary rebates were, exactly how much the fees were. And if you look at the total down at the bottom, you know, we've got over $8 million in fees and price protection rebates with only $26,000 in rebates. So when you hear the CEOs of Express Scripts, CVS Caremark, and OptumRx before Congress saying, we pass all of the rebates back to the employers. First off, they don't do that, but they'll say it. No one ever seems to ask them about the fees because so many of those rebates have been reclassified as fees, so they can with a straight face say, we're passing the rebates back. And that's sort of the gist of this somewhat complicated slide, and I apologize for that. So what about competition? You know, everyone says competition reduces prices. So let's see how competition works, what it does with prices of drugs trying to get on a formulary. So I would submit there's two things that prices can do. So for example, if you're building a house and you want to hire a contractor or architect and everyone is of the same quality, no one is your brother-in-law or your cousin's best friend, and they all are putting in very similar quality and you trust them all the same, they may tend to underbid each other. So the winner tends to be the lowest bidder. So in that case, competition drives prices down. However, when you're selling a house, if you've ever tried to buy a house that was the favorite house on the block, they put one day when everybody can put in their bid. And what do? You try to put in your highest bid. So consequently, competition drives the price up in that situation. So which situation do you think we have for our drug distribution? Absolutely. You know, we wonder why these prices keep going up year after year. And I've talked to some of the manufacturers about that, and they say that if they don't keep their prices up, and this isn't, I'm not, you know, taking them out of the blame game from drug pricing, but if they don't raise their prices, they may not have a place next year on the formulary. And the maddening thing is, if they do lower their price, will actually lower their list price, the PBM will demand the exact same amount of money in rebate and fees as if the list price were still higher. So there is absolutely no incentive to lower prices. It's a completely perverse incentive for higher priced drugs. And again, manufacturers don't get off the hook, but I just am trying to impress upon you, there's more than just who sets the list price in terms of incentive for higher prices. You know, so the higher the list price, the higher the admin fees. They're based on a percentage of the list price as well. It's not a fair market flat fee. There are transparent PBMs out there that work on a flat fee, doesn't have anything to do with the prices of the drugs, but they're not one of the big three. And they don't own or are owned by one of the major insurance companies. So it's very difficult for them to get business. I'm going to give you an example of cost savings by a large employer that got rid of their traditional PBM. And that's Caterpillar, the one that makes tractors and all of those things. Gosh, now it's probably been about 16 years ago. 3 years ago, CSRO heard about what Caterpillar had done to set up their formularies for their employees. They basically got rid of Express Scripts, used them as just an adjudication for a flat fee. And in setting up their own formulary, and I actually talked to their HR department to find out if a patient really needed a drug that wasn't on the formulary, could they get it? And they said, absolutely. If the physician asks for it, the patient can get it. But in those, well, back then it was about 13 years. In those 13 years since they dumped Express Scripts, they had not raised health insurance premiums by 1 penny on their employees. And I don't know of many other companies that can say that. So anyway, I digress. The higher the list price, the higher the admin fees, the higher the price protection rebate, but most important of all, the higher the patient cost share. Because when you get into these very expensive drugs, it's, for the most part, it's no longer a copay. It's not just like a $50 copay or even a $100 copay. It's coinsurance, and that can be as high as 20% of the list price of drugs. So you take a drug that I prescribe, maybe $8,000 a month, that means they're going to have to come up with $1,600 a month. And we wonder why patients need copay cards and copay assistance, because who can come up with $1,600 a month? I don't have any patients that can do that. So when they talk about copay cards enticing patients onto higher priced drugs, my patients with rheumatoid arthritis, they've already been through the generics, the methotrexate, the leflunomide, the hydroxychloroquine. They need the biologic. And for $1,600 a month, it's just not going to happen. So PBMs claim they save billions of dollars through their preferred formularies, through step therapy and non-medical switching. Let's look at savings calculated the PBM way. And yes, I use the example of a dress. So we have one dress, 2 identical dresses. So they're basically the same dress. One is listed at $1,000. The other is listed at $100 at a different store, same dress. Both are offered at 50% off list price. Which one saves you the most money? Well, according to PBMs, it's the $1,000 dress, because you save $500 on that one. Whereas with the $100 dress, you're only saving $50. So the PBM industry reports that they can save over $1 trillion in savings over the next decade. With savings of $1 trillion, I'm telling you, I don't think we can afford $1 trillion in savings with the way that they define savings. So be wary when they talk about savings millions of dollars, because they're out there buying $1,000 dresses. When the employer, think of it this way, the employer's got to pay $500, actually $1,000, and they probably only get back 20%, as opposed to paying a list price of $100. Remember that. So what is the result of formulary construction and utilization management tools? I would submit it incentivizes higher list drug prices. And again, many of the examples that I have seen in my own practice and have been able to ferret out support that idea. Higher cost sharing for patients. Everyone says list drug prices don't matter because they're getting it at all these discounts. They do matter, and they matter to patients. And it's not just commercial patients. Medicare Part D beneficiaries pay on the list price in the donut hole. Granted, for certain brand names, they get, it's paid on 50% of the list price. But one of the rules being put through, or trying to be, I have little hope that it will, is to basically take the rebate away from the PBM and Part D take away their safe harbor. They can't take the kickback anymore, and institute a safe harbor for patients at the point of sale, where they would then pay on the rebated price of the drug. But anyway, for the formulary construction, it results in formulary restrictions, step therapy, non-medical switching, and exclusions. So whenever I talk about this, people say, well, how do they get away with this? And it's this safe harbor from the anti-kickback statute. It's very interesting. Pharmaceutical manufacturers put money into foundations so Medicare beneficiaries can afford those drugs. And basically, they're saying they're enticing Medicare beneficiaries, giving kickbacks to Medicare beneficiaries. And according to the rule, it's true. And they pay millions and millions of dollars in fines from putting money into foundations to help Medicare beneficiaries pay very high priced drugs. And yet they can give billions of dollars to PBMs to essentially put a higher priced drug on the formulary, and that's completely legal. I think that's wrong. So who regulates the PBMs? The rebate rule that I'm talking about, it was proposed last year and got pulled back. I wrote 2 op-eds on it. One was published in The Hill before it got pulled back, and then the other one was published, I believe, in the Center for Biosimilars when it got pulled back. The Federal Trade Commission, they're the ones in charge of, antitrust, anti-competitive behavior, and yet over the years they have never met a PBM or a PBM merger that they didn't absolutely love. They're looking at some antitrust things with rebate walls, but I'm not going to hold my breath on the FTC. The Department of Justice allowed the mergers between the PBMs and the larger health plans. As far as the Senate and the House, I don't know. I can't. The problem is that there'll be a bill that's great, and both sides really love it. But unfortunately, whichever side proposed the bill, the other party has to vote against it, even if they like it. So it's been very, very difficult to get anything past the House and the Senate, and vice versa. Where this is where the rules come out of Health and Human Services, and sometimes there's the rule again about the rebate rule, pulling the safe harbor away from PBMs in order to give that rebate to the seniors. But there's been poison pills put in. It can't raise premiums. People say the rule is going to raise premiums on our seniors. No, it's not the rule that's going to raise the premiums. It's the PBMs who are putting together the formularies, not getting the rebate for their bottom line, therefore increasing the premiums on the seniors. So put the blame where the blame is due. I mean, if we're going to have price controls for drugs, we should have price controls for premiums. That's my opinion. Okay, so then if the federal government can't do anything with this, it falls on the states. And I have there in parentheses ERISA issues, because the states really only have jurisdiction over certain plans, the state plans, the exchange plans, but any of the large companies like Boeing and Hewlett-Packard and airlines and things like that, they're self-funded. And they're just sort of managed by the health plans. And the state, if they pass, a non-medical switching law, it really doesn't have jurisdiction over those large companies that are self-funded. However, and I know I'm getting a little bit in the weeds here, Leslie Rutledge is the Attorney General in Arkansas, and they passed a law that basically they're saying should cover ERISA plans. So PCMA, of course, not wanting any of the PBM's bottom lines to be touched by that state legislation, there's a lawsuit. And actually it went before the Supreme Court in October. And we have hope that if Rutledge comes out on top, when states do pass these pieces of legislation that, say step therapy and non-medical switching, it will have jurisdiction over those large self-funded plans as well. Board of Pharmacy has really tried to clamp down on PBMs. Insurance commissioners, not so much, particularly when insurance commissioners are elected, who are their biggest supporters and threw the most money at them are the insurance companies, which is why the insurance commissioner we have now is probably the first out of the last 3 that has not gone to jail. And then the attorney general. So that's Rutledge. And I think she's done a good job at bringing this to some type of, at least it's made its way to the Supreme Court. And this is just a copy of the brief that we filed. ATAP is Alliance for Transparent and Affordable Prescriptions, and CSRO came up with the idea of forming a nonprofit and brought American College of Rheumatology in, of which we're all members, and a number of other patient organizations taking no money from pharma to basically educate on formulary construction in America. And ATAP, we did file an amicus brief with Rutledge in this Supreme Court case. We're hoping we hear something about it in the beginning of next year. So I hope after all of this, you can see that the PBM market fails on accountability, conflict of interest, and most of all, transparency. You know, if we could even pass some type of transparency law to be able to see what the true prices are, how much money is kept by whom, and see if we can get some of that money back to our patients to make some of these drugs a little bit more affordable. So I'll finish with this little cartoon. Let's never forget that the public's desire for transparency has to be balanced by our need for concealment. And I think I've left enough time for questions, so fire away.
Thank you very much, Dr. Feldman. This is such a sobering talk. Ethics aside, that this kickback scheme is legal is amazing. And what is also amazing that a lot of us were not even aware of it. So we really appreciate this. I want to remind the audience that we have a Q&A bubble at the bottom of your screen. Please type your questions, and there are 2 already. One is, how are prices managed in other countries? This was actually something that I meant to ask as well. Is there a best example?
So their formularies are set up a little bit different. They don't have PBMs setting up formularies to make money. And Europe sometimes is looked at as like one country, but as we all know, it's not. And depending on the country, for some of these very expensive, they have a tender. And basically, sometimes one will win out. And it's based on how much they can lower their price. So I'll give the example of Humira. Humira is adalimumab, and there's maybe in Europe, I don't know exactly, but maybe 3 biosimilars for Humira. And one country was going to pick the lowest price, not the highest rebate, not the highest kickback, but the lowest price. And AbbVie lowered their price by 80%. So that country essentially got Humira for 20% of list price. And that's how it's handled in some of the countries. Others have national health plans, and there is some, you know, there probably is a little bit of rationing taking place, but again, it's the lower prices that gets picked, not the highest price concession, not the highest kickback. Canada and a couple of the provinces this year are mandating switching to biosimilars because they're lower priced. Biosimilars have had a hard time in the United States getting uptake because higher priced drugs tend to be favored. We don't have any pharmacy for the true biosimilars, not the insulins, but the true self-injectables. For example, my drugs are etanercept, the brand name is Enbrel. There are several biosimilars that have been approved by the FDA. And then adalimumab, which is Humira, there are about 5 biosimilars that have been approved by the FDA, but they haven't launched because of the patent thickets. But once they launch, it'll be interesting to see if PBMs actually put the lower price biosimilar on the formulary or not. But again, there's not that PBM middleman in the other countries.
There's a question whether your op-eds are available for reading anywhere.
Yes, in fact, what I'll do is I'll send a copy of them. In fact, my most recent one that was published in Helio this past November was Formulary Construction in America, Perfectly Legal and Perfectly Wrong. And I'll send the ones on the rebate rule and a couple others. I'll be happy to send that to Janelyn and she can send it out.
That would be great. Dr. Huntwork is asking, wouldn't ERISA plans be natural allies for reform? They pay the full price and don't get the kickback.
Absolutely. And in fact, PCMA in fighting against this actually has essentially lying and saying we can't have the states softening the protections for ERISA plan beneficiaries. And, you know, I'm a big tweeter at Maddie Room MD on Twitter. And I put, you know, nothing could be further from the truth. In fact, having states have some jurisdiction over it actually increases protections. So yes, but I can tell you the big companies, I don't want to say are lied to, but very oftentimes they're not really shown how all they're being told is how much money they're saving. And they say if we have any type of legislation on non-medical switching, et cetera, it's going to raise your premiums. And so they get afraid and they go, look, we don't want our premiums to go out. To go up. But Dr. Huntwork is absolutely correct that they should be natural allies with this type of protection, added protection from the state.
Thank you. I have another question. I have some years back, I've served in the local PBM of the VA. And we usually get the lowest price drugs on the formulary, and that's
yes. The VA is the one example, it's the one shining example that actually does go with the lowest price. As you may or may not know, last year, Renflexis, which is made by Merck, got the contract for infliximab at the VA because it was the lowest price. So yes, the VA operates a little bit differently.
Okay. I'm looking and I don't see any additional questions. With that, we really appreciate this wonderful presentation. It's a sobering presentation. Thank you very much. And everybody have a wonderful day.
My pleasure.